our Global Dysphagia Clinic 1. We have our moderator, Dr. Gayatri H. And we have Dr. Lakshmi, Dr. Naveen, and Dr. Deepthi as our panelists. So we'll begin it. Dr. Naveen will be joining us through online. He's a senior consultant in KIMS Hospital, Trivandrum. So I request Prasanna sir to talk about what Global Dysphagia Clinic. Over to you, sir.
Thank you, Shalava. Welcome you all. I think if audience can come in the front in the round table, it will be nice view for the speakers as well. We have two parallel sessions going on, and this is the launch event. This is not the actual event that is going to take place throughout the year. I'm definitely sure that some of you have already attended Echo Dysphagia Interdisciplinary Clinic, where case presentation is done or didactic is taken. And here we are for launch of something beyond the national program. We are going to go international, have more people join us, either as hub or spoke, who would be either presenting a case, expecting other countries to help out in clinical decision making, or we ourselves can grow with all the outputs or options that the international delegates are going to give. So we have a set of three dysphagia clinics, a global dysphagia clinic for this conclave. And this is just the beginning. We are going to have regular programs, and it's going to be for closed group only. We are not going to share it via WhatsApp or social media. We are going to have closed group discussions because we want commitment for growing together. It is not that, okay, today I am free, I'm going to attend. No, I'm going to involve this program in my curriculum as a clinician or the program schedule, whatever I'm doing, right? This is important for us because the growth here is much faster. Learning is exponential. And just like how you would prepare for examination, group studies for some probably would be the best kind of preparation for exam, right? But some people may not be able to join because of any reasons, logistics or any other aspect. So we are going to make things available for them as a resource in the website as well. So we have opening batsmen for Global Dysphagia Clinic. So all the three are specialists in pediatric dysphagia. We did announce echo dysphagia, with Lakshmi ma'am and Chitra ma'am. I think back almost 1.5 years back. We didn't see much of success in pediatrics. We did good number of sessions in adults, especially neuro and onco, I would say, because it was from HCG and our fellows were presenting. And I request you all to make the best use of this congregation of hub and spoke model of learning. And it is supported by ECHO India. ECHO is a capacity building platform, which is going to support you end to end from onboarding till the feedback or assessment aspects. So I again call upon Shalabha to introduce the moderators and Dr. Naveen Jain, who has joined us online, to discuss about a case or answer some of the queries that the presenters will be posing to them. All right, enjoy and have a nice day today. Thank you.
So having known about the panelist and the moderator, let's move on to case discussion. So here comes Rashmi for the first case presentation.
Good morning, everyone. This is Tejaswini from Ayush Mysore. So we are going to discuss about oropharyngeal and tracheoesophageal fistula. So this is the case study on bronchopneumonia versus aspiration pneumonia.
Just focus to the mic.
So about this case study, this is on oropharyngeal dysphagia across tracheoesophageal fistula. Coming to the background, this is a baby of 10 days old post birth was diagnosed to have tracheoesophageal fistula. The baby had issues associated to swallowing and was having aspiration to breast milk. Post-surgical closure of the fistula, baby was again done breastfeeding, but baby desaturated to 75 respectively. Heading towards assessment, primitive reflexes as in rooting, sucking, and swallowing reflexes were assessed and showed normal reflexes. Facial muscles were assessed, but no difficulties were seen. About treatment, suggestion of facial stimulation, stimulation of laryngeal areas, and query suture healing since surgery of fistula was done, and post 24 hours trial was given to which baby desaturated. Postural changes, there were query, alternate feeding methods, heading towards discussion.
Could you go to the first slide?
Yes, sure.
Okay. So the baby had a tracheoesophageal fistula was diagnosed at birth, right? Dr. Naveen Jain, uh, can you hear us?
Yes, ma'am. I hope
Are
you
you
can
there?
hear me too. Are you able to hear me? Hello? Hello?
Good morning, Dr. Jain.
Good morning.
This
Are
is
you able to hear me?
This is Gayatri Attangadi. The case was presented, which was 10 days post birth, who was diagnosed with the tracheoesophageal fistula. Can you tell us a little about this condition for our audience and why there is a chance for this child to have aspiration?
Right, ma'am. Good morning to all the listeners of this wonderful conference. Tracheoesophageal fistula is a condition where we may have the milk that baby drinks from the esophagus entering the trachea, and that too not at all times, only on some occasions. This is because most of the tracheoesophageal fistula are what we describe nowadays as N-shaped tracheoesophageal fistula, not H-shaped. When we mean N, the two limbs of the N, the standing limbs of the N are the trachea and the esophagus, and the connecting limb is like a shape of N, not like H. So it is like this. So which means there could be times when the end which is in the esophagus is lower than the end which is in the trachea. And therefore baby may have aspiration of milk when the milk flow is very high, and a contrast study also may sometimes find it challenging to pick up the same. Now when this is happening, the amount that goes in may cause not only problems in actual volume of milk going in and causing aspiration, it may start off defensive mechanisms in the baby, because bringing of milk is risking the baby's airway, and the baby may have severe abnormalities in trying to defend or protect, and the baby may not want to swallow at all. Diagnostic challenges are not going to be discussed because this is mainly about dysphagia that we are going to discuss. I hope I have answered the question that you asked.
Yes, yes. Thank you, sir. I also want to ask you how early this is diagnosed and how it is diagnosed, like how it gets confirmed that it is TEP, tracheoesophageal fistula.
With advancing prenatal diagnosis is not uncommon these days. Our high-risk obstetric teams might even tell us before delivery that they're suspecting one. In the newborn period, the severe forms may sometimes show up as frothing in the mouth and difficulty, and they get intubated at birth itself. But we have had babies who have lived for 1 month also before they actually got diagnosed. So the diagnosis in the first two cases, where there is an esophageal atresia and there is no swallowing, you pass a feeding tube, you see a U-shaped the turn of the feeding tube is very, very easy. And they would be picked up on the first X-ray itself, because most of us pass feeding tubes for taking X-rays. But if there is no esophageal atresia, it can get missed for weeks together.
Okay. Any other, apart from X-ray, any other radiological diagnosis can be
Yes.
done?
Yes, you can actually do an endoscopy to try and look for the opening in the esophagus. We have even had occasions when we were unable to confirm easily, and you pass a barium swallow, and then you might see it is a dangerous thing to do, but you might see the highlighting of the airway. Sometimes when nothing else works, this also can be done.
Okay. Okay. And how soon should they be operated?
If most of them would come out premature babies because of the polyhydramnios that is associated, so they will come at 34 and 35 weeks gestation most of the time. If esophageal atresia is there and they think that they are a long gap atresias, then they would operate them on 2 stages. And the first stage, they might create a salivary ostomy, or they might just so that baby can start swallowing safely. But if it is a typical one where they can operate early, then it's often operated in second, third day itself. But retaining a swallowing experience becomes a challenge. Many of these babies may be allowed oral feeding only after the surgery heals, and that may be several weeks sometimes.
So in that, till that time, do you recommend a OG tube or an NG tube? For
We
feeding?
all use OG food as an habit. I'll probably listen from you whether you think NG tubes are better, because NG tube has one advantage: it doesn't slip too often, but then it tends to occlude the nostril where you pass the NG tube. So we tend to use the OG tube, and probably we are not using gastrostomy too early, because many of them within 2 to 3 weeks are able to take feeds orally. In our unit, once the primary surgery is done, we allow pacifier to be used on the baby so they learn sucking, and very soon on the breast. But I'm going to hear from you how you would do it better.
Okay. And what is the prognosis post-surgical? Do they revert to breastfeeding and soon? And if so, within how many days?
Prognosis is good in 80% babies, because 20% can have other associated anomalies which can affect long-term outcomes. Even CNS problems can be there which can disturb feeding. But in those babies, 80% babies who do not have this, if I look back at maybe the last 20 babies we saw in the last 4 or 5 years, most of them, despite of prematurity and surgery, are able to get back to breastfeeding. Some of them land up in oral feeding with a bottle because the mothers have not breastfed for 2-3 weeks, and that's the challenge.
Okay. Thank you, sir. We'll now go to the other part of the discussion. Can you show the next slide? No, the same case, the next slide. Yeah. Okay. Facial muscles were assessed, no difficulty seen. Can you go next? Okay. Now here talking about the treatment part, I would like to ask my colleagues, Dr. Deepti, how would you treat such a child?
Very good morning, everyone. First and foremost, this is a 10-day-old baby. So I'm going to talk majorly related to the feeding related aspect. So what we know that is there is suck, swallow, breath coordination, which has to happen when a baby feeds. And a baby is 10 days. So obviously breastfeeding is what is the norm in such conditions. When the suck, swallow, breath happens, we should understand that the pharynx, the oropharyngeal region, is a common pathway for both the milk to go in as well as breathing to happen. So the suck, swallow, breath coordination requires the pharynx, oropharyngeal region, so that the food as well as milk, they enter the same pathway, but it happens alternatively, isn't it? So when there is a patient with oropharyngeal, esophageal and tracheo, this fist cleft, okay, so what happens is obviously the muzzle is separated because of the cleft. And not only the muscle which is separated, the neural supply is also altered. So when a surgeon does surgery and close the fistula, they anatomically close it, but we are not very sure how the orientation of the muscles happen. So the muscle orientation need not be as we see typically, as we have learned in our textbook. It will be altered. That is one thing. On top of it, the neural supply will also be altered. So there will be a deficiency of the neural supply as well. And the third thing is the oropharyngeal region has mechanoreceptors. So these mechanoreceptors are able to perceive the pressure changes. Like for example, if the milk enters the oropharyngeal region, there has to be a correct volume of milk to enter into the oropharyngeal region, so that that volume of milk exerts a particular amount of pressure on the mechanoreceptors. So when that mechanoreceptors gets triggered because of this volume and pressure, that is when your swallow reflex is triggered, and that is when the milk enters into the esophagus. Now that this is a patient with such a kind of defect, what will happen is there is an alteration in the muscle orientation, there is an altered or deficient neural supply, and there is an atypical mechanoreceptors which trigger the swallow reflex. So because of all these things, what will happen is obviously the baby will find it difficult to swallow. And definitely there is a pain which is also there associated. So the baby will reject, feeding and all. And there is they have mentioned about the desaturation issue. So that is one thing which we really have to focus upon, because as I told, the oropharynx is a place for both your milk as well as your air. So usually when I am handling babies like this, what I do is I have my oximeter attached to the baby, and I start with small volumes of milk, trigger the swallow reflex and suck reflex, and help the baby out. And no, but yeah, I forgot one more thing. Thank you.
Dr. Lakshmi, can you add to this?
I think I'm coming from SRMC. I think our unit is similar to, maybe similar to what Dr. Naveen Jain is also coming from. So in this case, at 10 days surgery done, so we would do, the baby is on OG tube, let's say, then we would do some kind of a stimulation. So just non-nutritive looking and non-nutritive sucking to see whether the baby's suckle is good, and then slowly build on the suck, swallow, breath sequence. So we would start doing cup feeding or Palade trial slowly and see whether how the baby is doing. So if the NNS is good, then maybe also do some NNS on mother's empty breast, and so that the breastfeeding can really be pushed slowly. So keep that going, and then we will do Palade or cup feeding. And as Deepti said, move from OG tube. I think the aim will be to move from an OG tube to a cup feeding first, and then slowly to breastfeeding.
Yes, you want? Okay.
Just wanted to add on about one thing. Sir mentioned about OG tube. Clinically, what I have seen is most of the doctors definitely prefer OG tube, but practically when we see the OG tube is put inside the mouth and it is taped over here. So what happens is the tongue movement is restricted, and we all know that the tongue has to rest against the palate for a good orosensory perception. And when that happens, and also it creates a lot of aversion to feeding. Because, and what happens is, because the babies are fidgety, there is a lot of times when the babies inadvertently pull out the OG tube. So, and there is frequent reinsertion of the OG tube. So there is a high aversion which is developed in these babies regarding that. So as sir rightly pointed out, NG would be better. One, because it is retained in the nasal cavity and you have good oral, there is no obstruction within the oral cavity as such. So you can go ahead with the stimulation and, because the sucking action is not only for the purpose of feeding and, filling your tummy, but also it is a pacifying thing. So the babies not only suckle on the mother's breast for the purpose of nutrition, but also to fall asleep or, organize themselves. So we need to make sure that, we have to discuss with the pediatricians and all, and hopefully we can have an NG tube rather than a OG tube. That is one thing. And definitely, because this is a baby of 10-day-old, lactation is something which we really want to work upon. See, what happens is, because the baby will be in and out of ICU and all those things, the mothers usually don't get the support for establishing the milk supply and maintaining the milk supply. See, the production of breast milk, which I'm going to talk about in the next presentation. So it is all dependent on hormones. It is all, and just like we have your critical age concept, right? We have critical age. Within that 3 years, if language is developed, then good. Otherwise, no. The same way, the breast milk production as well as establishment is also critically dependent on the hormones. So if we miss out that time window, then the mother might not be able to maintain her milk supply or establish the milk supply. So these mothers need all the support we can. We have to work definitely with the lactation consultant and make sure that she is able to establish the breast milk and maintain it so that it can be given to the baby. And the breast milk contains all the nutrients required to heal the wound and, develop the gut system of the baby. And gut is one thing which is very important for our immunity. So if you drink breast milk in the very initial phase of your life, that means you have a very good gut system, and that means you have very good immunity and you can fight off the bacteria and all much easily. Thank you.
Yeah, I think we had a very good discussion about this case. And so we've heard the medical aspect in terms of how the fistula should be repaired and, how soon it should be done, how to wait for healing, how to try with non-nutritive sucking using a pacifier or an empty breast, as madam said, how to initiate that, how important lactation is, how soon one should go to lactation also, and try to resume normal feeds at the earliest. What are the pros and cons of oral, orogastric versus a nasogastric tube? Best would be to minimize the use of both and, kind of try to go towards normal lactation at the earliest with good positioning, okay, and early intervention. Again, here I want to, that we need to take the help of a lactation consultant. Also, where the mother who is not immediately able to lactate and feed her baby, one good thing which is done in our hospital is we have the human milk bank. So what the mother does till the time that she cannot feed her own baby, she expresses milk and it is contributed towards the human milk bank so that her milk ejection continues and her supply is, ensured. And when her baby is up to the mark that when she can feed her baby, then the breast milk is, the flow is continuing, so that is one more thing I wanted to add. Another thing is after feeding, resting the baby is again very important. Burping the baby is extremely important. Not making the baby sleep in a supine position is important. In a kind of flat position, it has to be in a semi-inclined and at an angle, so that the child does not regurgitate or it, does not have any aspiration post-feed. I think with this, we complete this case discussion. Can we go to the next case? Thank you so much.
Thank you.
I thank my the speakers who have contributed so much. We'll go to the next case.
Next case would be presented by Ms. Rashmi. Sorry, Ms. Reshma.
Yeah. So, good morning, everyone. Myself, Reshma Anna. I'm from Nasima Institute of Speech and Hearing. So, today we'll be discussing a case on Pierre-Robin sequence. So, the background of the baby is like this. A baby of 4 months of age was admitted for aspiration pneumonia. On further medical examination, it was determined that the baby had retronathia, unilateral cleft on the palate along the midline with a chorea of submucous cleft condition. And the baby was also suspected to have a laryngomalacia, which was later confirmed by fibro-optic endoscopy. The baby was also having nasal regurgitation. The genetic evaluation revealed baby has Pierre-Robin syndrome. So, moving on to the assessments, rooting, sucking, and swallowing reflexes were assessed and showed no rooting or proper sucking reflex. Facial muscles were assessed, but no difficulties were seen. And the baby also had intense crying when long nipples were being used for alternate feeding. The baby was having coughing intensely whenever breastfeeding was done. So this was the treatment plan which was done. Suggestive facial stimulation, stimulation of the laryngeal areas, peg feed till surgery is initiated, obturated based feeding materials. So that's the case. Now we are open for discussion.
Okay. Dr. Jain, are you there?
Yes,
The
ma'am.
first few questions I want to address to you.
Sure.
Okay. Dr. Jain?
Can you hear me?
Yeah. As you heard,
Are you able to hear me? Yeah.
yeah, this is a child, this is a 4-month-old baby with the Pierre-Robin sequence. And I would like to ask you to give a little details about what this Pierre-Robin sequence, what are the things which are seen because of which it may impact this sucking and swallowing. And secondly, also to explain a little about laryngomalacia. Thank you, sir.
Right. Sure. Thank you so much. We see a very large spectrum of babies Pierre-Robin sequence severity. In the most severe form, they may not even take off at birth. They have very great difficulty in resuscitation. We may find it difficult to even establish an airway. I can remember a baby who we lost and not being able to even establish airway. In the second severe spectrum, they may have no difficulty in breathing if they're positioned well in a prone position, but still require a nasopharyngeal airway. Most of us use modified airways in the form of a 2.5 endotracheal tube, which is taped across for weeks together. And then the baby learns to feed, understandably with a lot of challenges. The third category is there, which is very grossly unrecognized, is babies who come with a small chin, they don't have a cleft palate, and they have snorty sounds. They keep getting nasal drops in the OPD for several weeks together. So having said that, laryngomalacia I would take in as a continuum of this problem, not because it's probably the same disease, but probably because it gets under-recognized in the outpatient settings. The babies would have very throaty sounds. Some of them would not cry effectively, and some of them would be having a lot of substernal retractions. Some of them don't grow well, and then they get an endoscopy and they get a treatment. But the ones who are not sick enough to get an endoscopy, they again get overtreated as respiratory illnesses and with medications, nasal drops, and so on. So swallowing issues in pure laryngomalacia, what we call congenital laryngomalacia, we don't see too often, except if parents get scared. But in Pierre-Robin, we do face a lot of challenges in establishing feeding because the chin is so small and tongue movement is so limited.
So for Pierre-Robin syndrome, do you suggest, because of the glossoptosis that they have, do you recommend if the tongue is stretched a little, and some doctors also do a little tie of the tongue, and tethering of the tongue outside? Do you, what do you have to say about that?
We have had unpleasant experiences with this procedure. We have probably done glossopexy for 4 babies over the last 20 years. And one thing is, if the baby is a little older, let us say 1.5, 2 month old, and or if the baby is a term-born strong baby, the surgery is technically very, very challenging. During the surgery, they all crash because when you try to fix the tongue and oral secretions, intubation is very difficult. And one baby who we did glossopexy died at 4 months of age when he came for hearing assessment. Bera, he was sedated and they couldn't resuscitate the baby. He was the only baby who died in the last years because of a difficulty managing airway later. 2 babies went home with glossopexy, but both were done within a few days of age, not months. But they have a lot of challenges with feeding, and literature internationally also seems to suggest that it is not a popular procedure, but I'll hear from the other faculty.
Okay. But how soon do the children with Pierre-Robin sequence, how soon do they, like, what is your experience that they come back to normal breastfeeding?
The second category which are presented who don't have to get intubated at birth and don't have very critical airway, and most of them by end of 2 to 3 months, because they get offered alternate methods of feeding like palada, several types of bottles. My take is that not even 10% get to breastfeeding eventually. They all land up in getting in palada and bottle feeding, and they keep alternating between the Haberman special bottle as well as the ordinary bottle, and we have never been able to figure which baby would take both. Many times you buy the expensive Haberman bottle and then the baby takes the normal bottle. But I think it also involves how to train the parents to use the special bottle.
Okay. Thank you, sir. We'll go to the other part of the discussion. So please be there for the next case. Can we go to the presentation and to the management slide? The next one. Yeah, that's not fine. Okay. Okay. Now here I want to ask Dr. Lakshmi what you think about suggestive facial stimulation and stimulation of the laryngeal areas. What do you have to say about that?
Yeah, so I'm wondering why we would do that. So why would we do facial stimulation and stimulation of the laryngeal areas? So we need to have real reasoning for why we are doing this. So I think, as sir said, I think there's a whole spectrum in this case. So each child will be very different, and it's a syndrome. And laryngomalacia is just one part. And typically in laryngomalacia, mild cases, there will be just a floppy airway, and suck, swallow, breath sequence will be affected. But mostly we will be able to manage with pacing and positioning. So unless it's very severe, in which case, of course, a tracheostomy may be needed. But most laryngomalacia cases, we are able to manage with pacing and positioning feeding. But in this case, it's a syndrome. It's a Pierre-Robin syndrome. So that is definitely a big picture that we have to keep in mind. There's a cleft, and the surgeon would want the baby to gain weight slowly so that baby can be ready for surgery. So definitely there's a lot of pressure to feed well, gain weight really, and there's a lot of anxiety. So this child, I'm assuming, is on NG tube. And so in this case, we would have to start, baby is getting possibly nutrition through the NG tube. So we have to see how we can facilitate some kind of an oral feeding. So rooting is poor, suckling is poor, also likely because of all the medical complications. Baby is averse, baby has had tube feeding for too long. So all of that is possibly causing this delay in the other reflexes also. So definitely we would get the baby going on some oral sensory motor stimulation slowly, depending on how the baby starts responding. We'll start doing that, and that would actually help with these suckling behavior. And see, we have to see, because depending on the tongue, depending on how the tongue is moving in the oral cavity, we'll see some pattern, and then move to oral feeding if we can, through a cup feeding or a palade, see whether we can do that. And breastfeeding, establishment of breastfeeding is very tricky. Very few children get to breastfeeding. Lot of persistence is needed from the mother as well as the help from the lactation consultant, which is really, we have to really persist, and it depends on the mother. I have seen a child who was on Palade and went on to breastfeed also. So there's a lot of effort that has to be put in by both. And so, yeah, that would be, so this is not something I will do directly, facial stimulation and stimulation of the laryngeal areas.
Dr. Deepti, what do you have to say?
I work at a center where we have one of the highest cleft operations being done. So Nitya Meenakshi Craniofacial Institute is there. So we see a lot of babies with pyrorobin sequence. So I'm going to talk with respect to what usually I see clinically. So one thing is when pyrorobin sequence is there, as she's mentioned, there is retrognathia and there is a cleft of palate as well. So most often in these babies, we see midline cleft, a U-shaped, bell-shaped cleft. So to retrognathia. So when there is retrognathia, but the tongue, the mass of the tongue is adequate, only the jaw is what is small. So what happens is, it's like, you know, you have a small box, but you want to stuff too many stuff into it. So it's like that. So the oral cavity space reduces. And because the jaw is retrognathia, the tongue also moves backward. So when that happens, that is what we call, what ma'am was talking about, is glossoptosis. That is, the tongue occupies a large part of your oropharyngeal region. And when we were talking, oropharyngeal region is important for breathing as well as your swallow. So this is one thing. And also the vertical space within the oral cavity is also reduced, which is important for the peristaltic movement of the tongue for the purpose of feeding. So that is all reduced. So, and breathing becomes very difficult in them. They frequently desaturate. And as sir was telling, a particular position of the baby facilitates better breathing in them. But we cannot make the baby sleep on the same position all the time. Like when you are sleeping also, inadvertently, you will change positions. You cannot be sleeping on the same position. So practically, it is a bit difficult and tricky, especially when you have a baby who's fidgety, who's irritable because of breathing issues, because of the stridor and all those things. So most often what is done at our center is glossopexy is done for all these babies. The reason being, if you can breathe, you survive. And because you survive, you feed. So first, the priority is given for the purpose of breathing at our center. The surgeon does that surgery, and then we do the feeding management. And again, this is a tricky condition where when glossopexy is done, as ma'am was pointing out, the tongue is brought forward and sutured on the tip of your lip. So when it is sutured on the tip of the lip, what happens is your tongue is anchored forward. And we all know that when we have to feed, when we have to suck or swallow, your tongue movement, a forward backward movement has to happen, and peristaltic movement has to happen, and your piston action of the tongue has to happen to swallow. So now all those things are restricted. So, and on top of it, you have cleft of palate, that is VP dysfunction is there. So there are so many openings into which the milk can enter into, and that is when you have a lot of aspiration in these babies. So feeding these babies is quite tricky. So coming to the next point, can we do breastfeeding? In my clinical experience, I have not seen many babies, any baby for that matter, who has been able to successfully breastfeed. But I have been told by my surgeon and now by Lakshmi ma'am also that there are cases who can breastfeed also. But what happens practically is, now when a baby has to feed, the baby has so the baby has to open the mouth quite wide, and then your breast tissue goes into the mouth, and then the baby is able to suck on it. But when you have a jaw which is retruded and you have an upper jaw which is like this, so no matter how much you open, it's not adequate for the tissue, your breast tissue, to enter into the mouth of the baby. And obviously, because glossopexy is there, again, the difficulty in creating the suction pattern is also difficult. Yes, ma'am. Obturator, practically what I have seen is they first and foremost, they reduce the oral cavity space quite significantly. Already the oral cavity space is reduced. On top of it, you have an obturator that reduces the space within the oral cavity significantly. One thing. Second is the obturator seems can become loose quite often. So because these babies will not have teeth currently, they will have to use tape and all those things to fit the obturator in place. So that again is an aversion to the baby. Third thing is, because there is an obturator, again, we know that sucking and swallowing, everything happens because of the sensation in the oral cavity. And this palatine obturator obstructs that. So your mechanoreceptors, your tactile receptors, your thermoreceptors, all those things which are present in the oral cavity, all of them are cut off because of the obturator. So it might help in compression a bit, but not in, the sensory aspect is compromised.
Okay, that was a very good discussion on the challenges also that we face in feeding with children with certain anomalies like this. So I want us to be knowing where we can really go aggressively and intervene, where we have to hold back, wait, watch, and ensure that the child is having normal nutrition, maybe if not through prolonged OG tube or something, maybe a peg may be an option, so that nutrition doesn't suffer. And when it's seen that in Pierre-Robin syndrome, when the child, grows in age a bit, then the retrognathia doesn't matter to that extent. And then feeding can be, normalized. So with this, we'll go to the next case, the third case.
Thank you all.
Very quick, because one case is still waiting. 11:30.
Okay, just to finish up with that case, I would suggest Heberman feeder or regular bottle feeder only for this, with pacing the feeding. And in my clinical experience, I have felt that palladi feeding is a bit tricky because the mothers are in urgency to feed the baby. So there is no control on the volume of milk being fed. So that's one thing.
I think the thing is that, as I said, we don't know which will work for which baby. So I have seen babies on Haberman, on normal bottle, as well as on Paladai. So it's really, everybody gets everything, and then they try and whatever works for both the baby and the mother. Yeah.
Thank you so much. We can go to the third case.
Yes, ma'am.
And I think we'll have to cut short a little on the discussion because I think we are running short of time.
Yes. So thank you, Ms. Reshma, for that interactive presentation. So for another wonderful case presentation, here comes Ms. Nia Sharan from Nasima Institute. Over to you.
Hi, good morning all. I'm here to present a case study on bronchopneumonia versus aspiration pneumonia. So coming to the background, a baby of 2 months of age was admitted for bronchopneumonia caused by bacteria Staphylococcus pneumoniae. So the baby had no prenatal or neonatal medical history. There was no significant prenatal and neonatal medical history for the baby. On further medical examination, the baby was having difficulty in swallowing breast milk, had signs of malnutrition. The baby was coughing, and marked signs of aspiration was also seen. The chest X-ray has revealed white hazy patches on both left and right lung was there. Coming to the assessments, we have done rooting, sucking, and swallowing reflexes were assessed and showed no rooting or proper sucking reflex for the baby. Facial muscles were assessed, and difficulties were also seen for the baby. VFS revealed baby was having signs of aspiration, pulling at the level of valleculae. Coming to the treatment, suggestive of facial stimulation, stimulation of the laryngeal areas were also there, and there was postural modification which was done. Consistency modification was also there. Now coming to the discussion.
Okay. Dr. Naveen Jain, my first question is to you. Can you help us differentiate between bronchopneumonia and aspiration pneumonia and the medical line of treatment in both?
Thank you, ma'am. I think awareness to this condition would be required besides looking for wonderful clues that were provided by this presenter. She spoke about baby having failure to thrive, something which is not looked at very often. So a baby who comes to the hospital at 2 months of age and has not been gaining weight, that is the only job a baby is supposed to do, to drink milk and gain weight. So if he is not gaining weight, there is an underlying problem which does not allow the baby to do a basic function. And that has to be severe central neurological problem. And sometimes the central function may be okay, it's only a local problem with feeding. So I would probably extend the case to a generalized neurological issue than just a local issue of swallowing and feeding issue coordination. Most of them would have underlying global developmental issues. The babies after that, once they develop the aspiration, are going to be very challenging to differentiate in terms of whether it is infectious pneumonia alone or an aspirational pneumonia. There can be specialized studies which we often dwell upon, like even trying a nuclear scan or to see how the swallowing is happening and see whether the nuclear material falls into the lung. But I think all this would be a starting process, would be a good history taking by asking the mother what happens during feeding, a physical examination for looking for pooling of secretions in resting state, and then, of course, failure to thrive and neurological examination, head growth. But once the pneumonia is there, they all just look the same.
Thank you so much, sir. And I've heard that you are attending another neonatology conference, and despite that, you gave so much time to us. So I think all of us are very grateful to you. Can we put our hands together for Dr. Jain?
I'm learning and I'm enjoying this, and I wish I can. I wish I could attend the whole conference, to be very honest.
Next time, maybe we can have a separate session by you, sir. Thank you so much for your participation. We go to the second part of the discussion. In terms of this baby who has bronchopneumonia and the feeding issues as such. So I'll ask Dr. Deepti, what are your thoughts on this?
Ma'am, as this is a 2-month-old baby with bronchopneumonia, one thing is I would like to work with the OT or a PT, especially because these babies should be able to expel the, the mucus out. So there, I had seen one patient personally in my clinical thing where the OT helped, did some vibratory thing where they tapped the baby's back quite frequently and help the baby cough out the excessive secretions and all. So that is one thing I would like to work upon in this baby.
Dr. Lakshmi, what are your thoughts?
I think secretion management definitely seems like something we will do first, because pooling in the vallecula, so a lot of secretions. So definitely go slow, very carefully, talking to the pediatrician always, whoever the primary pediatrician, carefully. I think once we will have to see how to initiate swallow so that secretion can be managed well. If the swallow is there, looks like it may be there. So if swallow is there, then definitely try and do secretion management, get the baby to swallow, so that we can avoid aspiration of saliva itself, and then go slowly to oral feeding. So if the baby is on NG tube, then the same idea as well. It seems like there's a global neurological delay. Then we would do again stimulation, oral sensory motor stimulation, and then slowly get the baby to do oral feeding.
One caution I want to give is when we are deciding any techniques as such, let's think why we want to do what we are doing. Okay. So now if this baby is having pneumonia, Okay, that means we are worried about the respiration part, right? So all this is more like a passive management that from our side till the baby's airway is safe, till the suck swallow breath synchrony is established. I think we don't have so much of a active, feeding aspect as such. Wait and watch is one of the things. Another is, why do facial stimulation? Because this baby doesn't seem to have any oromotor issues. If the baby is having bronchopneumonia because of an infection, likely that the oromotor supply is going to, oromotor functioning is going to be within normal limits. So why do facial stimulation? Another is, there is a big no-no about the stimulation of laryngeal areas. In fact, all our oromotor stimulation, perioral stimulation is only related to the perioral surface and nothing to do with the laryngeal. We do not do laryngeal stimulation because in fact, for when you want to rouse a baby, maybe a baby or in fact in adult coma stimulation, you do a sternal rub and a little of this to just see whether the patient can get roused. So this is something which is not a technique to be used and definitely not in neonates and infants. And in any of our therapy, we don't really do laryngeal area unless maybe it's a voice case or some other muscle tension dysphonia, something else. So in fact, in terms of pediatric care, I think we can, write this off our, to-do list as such. And consistency modification, again, for a 2-month-old will not have much of a variety to choose from. It is going to be thin liquid. Okay, so that is something which we have to take care. Only whether the milk goes orally or whether it is going through a OG tube, that is our concern, or a peg tube, that is our concern. But mainly if there is a respiratory issue, safety is our first concern. As madam said, whether the airways to be established, if the baby survives, then the feeding. That order we have to really keep in mind when we are dealing with any child with respiratory distress. I think with this, we have come to the close of our discussion, and we had a very good 3 presentations from our student presenters. Give them a big hand. So, and we thank Dr. Naveen Jain. I also wish to thank our other speakers, Dr. Deepti and Dr. Lakshmi. Thank you so much. With this, we come to a conclusion of this panel discussion. Thank you all for patient listening. Any questions? Can we take any questions from our audience? Do we have time? It's your call.
One or two, yeah.
One or two questions. Anyone? A quick question? And address your question to which speaker you want it to be addressed to, which panelist.
Ma'am, my question is for Deepti ma'am. Ma'am, the very first case that we spoke about, you said that the neural misalignment happens because of the surgery. So ma'am, does it?
Not because of the surgery. They're
It may
born
have-
with neural misalignment, and when they try to fuse it also, it will not be the typical what we see in the textbooks. That's
Okay, okay. So ma'am, will the level of the tracheoesophageal fistula also make a difference? Like if it's
Yes, definitely. Where
ma'am-
exactly is the fistula? Is it in the upper part of the esophagus, closer to where the swallow reflex is going to be triggered? Then definitely it will affect. But even if it is down, also the peristaltic movement also is controlled by the central nervous system, isn't it? So there also it might be a bit of a problem.
So ma'am, is there any special care that we need to take for a higher versus a lower TEF?
I think persistence is what I believe is going to work. You have to gradually start, feed the baby slowly, increase the volume. How you do for the adult thing also the same thing, but in a smaller volume with lot of patience. That's the thing.
Thank you, ma'am.
Any other questions?
Can I ask a question, ma'am?
This question is for Deepti ma'am. Ma'am, actually, when we work with the neonates, we often get problem with the overflow of breast milk because of maybe irregular SSB. So is there any, like, what the kind of management that we could do to control the flow of the milk?
Like the mother has excessive milk.
So yes.
Okay,
And
and
because of
uh-huh.
maybe there might be many issues with the child, that the child is in the NICU.
Uh-huh.
So there was no contact with the mother.
Uh-huh.
So, and the child is in NG or OG.
Okay.
So and then when we felicitate breastfeeding,
Uh-huh.
so there are issues when the child
Yes.
has started sucking, and then
Okay.
so we do find the difficulties in regulating the SSB.
Yes.
Yeah.
See, one thing is, if the baby is in NICU and the mother has not been able to breastfeed regularly, there could be two things. One, there is milk ejection reflex, which is hyper. The second thing is the mother can be engorged because there is excessive milk and she's not
Exactly.
removing it. To tackle with excessive like hyper milk ejection reflex, one thing which I have learned is that applying cold press, not too cold, but cold enough. Yeah, so that kind of reduces the milk ejection reflex, and that controls the milk flow. Second is the engorgement thing. So when we shouldn't allow the mother to get engorged. So that is where ma'am was telling, repeat, removal of the milk is very important. So one, it will establish the milk supply. And secondly, if we allow the milk breast engorgement to happen, there is a high chance that abscess can happen. And when abscess happens, then that is a big issue. The mother has to undergo surgery, medical treatment, and all those things. And that inadvertently, reduces her breast milk supply. So those things have to be handled.
One more question.
Sorry, ma'am. We have one more question regarding the oral stimulation which we give to the kids. So are we supposed to give the oral stimulation tone based? Because that becomes very difficult for us.
I'll ask Dr. Lakshmi to answer.
Yes.
Okay, so I think the reason for doing that really is these babies are on NG tube, we are saying, right? So, and if there's no stimulation, then there's likely to be longer term aversions. So I think partly you want to definitely make sure that there is some stimulation. But all the cases that were presented, they're likely to be on NG tube for some time. So you definitely want to do some stimulation, perioral as well as oral. In one case, we were doing NNS, non-nutritive sucking. And so the idea is, of course, to develop the suckling and to proceed ahead and get good suckle swallow breath coordination. The other idea is also to do for just to avoid aversions, right? That's the kind of problems we see largely. Kids who are on NG tube for 1 year, 2 year, who come to us who are not taking, because they develop very severe aversions, really oral aversions. They won't even allow you to touch the face and all that. So part of that is also to avoid aversions. So
that was a big question like we had.
No, so the idea is you have to do it with some pressure, right? You're doing some stimulation, it has to have some effect, right? Of course, if there is a hypotonicity, we didn't see that in any of these patients, right? So if that is something that you can work with them, then it is easy, because I think they are sometimes better equipped to identify that early on. We can do that, but sometimes it's difficult for us to identify that early on. So if they are able to identify that early on, and they can help us with that, at least tell us, is it hyper or high? If we will get there soon, we will get there after some time. After the baby becomes a month or two, it's easier for us. But for a very early infant, sometimes they are sometimes better at that than us, I would say. So I always would ask them. So some of the early neurological examinations, and sometimes they are able to catch this finer details better than us. So I would ask them to check that. So if you have that expertise, then definitely go with that. So if you know that, if you're able to get that expertise and identify that, then work with them.
Yeah,
Thank you, ma'am.
I feel with each of these discussions, we realize how much there is still to learn and how much we have to learn from other team members. So one suggestion which I always give my students is that, try to attend allied health professionals conferences. So if you go for a neonatology conference or you go for a pediatric conference, you're going to get many, many more insights into what we should do or what we should not do. And it increases our horizons for, our own management and our own scope of practice as such. So on that note, I think we will end this discussion. So thank you all, and thank you organizers for having this first inaugural session of this GDC, which they are going to plan. And we look forward to further meetings related to this. And knowing Dr. Prasanna, I think he has many, many more ideas in his hat. And one by one, he brings these out. So we look forward to what else is awaiting us. Thank you so much for allowing us to be starting this inaugural event. Thank you. Are